So there are different factors which are responsible for the production of these control movement. But in case of any alteration in this factor will lead to the positional fault development. Among them, the one is the changes in the articular surfaces of the joint, which can be due to in case of the osteoarthritis, in case of the fracture, in case of the some kind of the external trauma, or in case of the changes in the articular cartilage. Like in case of the degenerative diseases, there is a change in the articular cartilage. So both the changes in the articular cartilage and the surface of the articulating bones may lead to the development of the positional faults. And the third one is the changing in the fibers of the ligaments and the capsule. It may occur in different kinds of the ligamentous injuries, like in case of the ankle sprain or in case of whiplash injury. So these kind of injuries which lead to the tearing of the ligaments fibers will add not only the pain but also lead to the positional fault development. And the third and the fourth one is the change in the direction of pull of the muscle and the tendon. It can occur due to in case of like scoliosis, in case of the upper cross syndrome. So when there is a muscular imbalance, when the muscles of the one regions are in the shortening and the muscles of the other regions are in the lengthening, so it will lead to the abnormal forces at the joint, and it also add the compressive forces at the joint. So these factors are required for the production of smooth controlled movement, but alteration of any one of these will lead to the development of the positional faults. So in case of different kind of injuries, it could be a ligamentous, muscular, tendinous, or the articulating bones, or in case of the sprains, these injuries always lead to the addition of some minor restrictions in the physiological movements like the flexion, extension, internal rotation, external rotations, adduction or abduction at the foot, dorsiflexion, plantar flexion, inversion and eversion. So the injuries always lead to the restriction to the physiological movements. And these restrictions are in the form of the pain. The patient will complain of the pain. The patient will complain of limited range. These limited range may be due to the pain or may be due to the poor muscular function. And the patient may complain that he's not able to perform a specific activity. Suppose a patient came to you, he said that he's having pain in the elbow region. So the problem is the pain. Or he said that he's not able to bend his elbow properly. So he's also having pain and there is the limitation of the range. So both are the combination. But sometimes the patient came to you and they said they are okay in their daily lives. They never felt pain. But sometimes when they do some twisting activity, when they use some kind of the screwdrivers, that activity is when female said that whenever she cooks the meal, it adds the pain in the elbow. So it means there is problem in the functional activity. So injuries may lead to the development of the pain, and pain may lead to the restriction, or patient may complain of the limitation in performance of the functional activities. So the Mulligan concept is all about to overcome these positional fault, these tracking problems. So whatever you apply a technique, basically you are correcting the positional faults. So this was all about the Mulligan concept, the correction of positional fault with the application of sustained glide in the right direction, or you can say that in the opposite direction of the positional fall, to make the correction and to keep that glide in that corrected position and ask the patient to perform that activity, the functional movement or the limited range. So with the correction of that positional fault, therapist apply that technique and the patient will perform actively. So the combination of these two will make the patient pain-free. So it was about the positional fault. Now let's start about the principle of treatment, which were given by the Mulligan itself. These are the simple principle. The first thing which is required, that is the assessment. Take the history of the patient, assess and examine the patient. The best history taking model was given by the Maitland. So you can use assessment of the patient by the Maitland model. In the Maitland model was purely of the patient oriented, and it was like the brick wall model. So he gave the three comparable signs which are always used as a signals, or you can say that measurable signs, which are used to measure the improvement of the pain, limited range, or the functional activity. So one was the pain, the second one comparable sign is the stiffness, and third one is the motor responses. So you can take any one of the comparable sign. So then compare it, apply the technique, then again ask that sign, is there any change in the pain? Is there a reduction of this stiffness, or is there any improvement in the motor responses? So in this way, you can check the loss of the joint movement, the pain associated with the movement, and the specific functional activities can be assessed with the help of the comparable signs of the mate lines. After getting the comparable sign, apply the passive joint mobilization. A therapist can apply the combination of the glides, which may be in the parallel direction or in the perpendicular direction, depend upon the joint anatomy or the positional fault. So when you decided the which technique or the which glide is required, then apply that glide in the correct treatment plane. So for the application of the Mulligan required the application of the glide at the correct treatment planes with the various grades of accessory movements. So the accessory glide must be applied at the correct treatment plane, and you have to check which grade of accessory glide or the movement is required. If patient said that you apply a technique and there is still pain, apply the glide in the opposite direction. So the combination of different parallel and perpendicular glide make a therapist to think about which glide direction is required for correction of the positional fault. But during application of these techniques, the one thing which is most important, monitoring of the patient, communication with the patient. You have to monitor the patient face, because the face is a part where you can get the expressions. Check the reaction of the patient. Is he feel. So whenever there is a pain, you can see the facial expression change. If there is a reduction in the pain, the patient face will be relaxed. So always monitor patient for the pain. And if there is improvement, you can easily feel that improvement from his facial expressions. If the glide is pain-free, ask the patient to perform the restricted range, to perform that functional activity. So, but make it pain-free. If the patient said that he is not having the pain and there is the improvement, ask the patient to perform it or to repeat it. In the lower limb and the upper limb, 6 to 10 repetitions are required, and in the spine 3 to 6 repetitions. But for the assessment, 3 repetitions are required. So with the application of passive techniques by the therapist and the active mobility by the patient, ask the patient to repeat those activities. So in this way, you can get the improvement in the comparable sign. If the patient said that there is no pain, he's absolutely fine, and there's a reduction in the pain, so you want to get further improvement, you can get that improvement with the help of the overpressure. But always remember one thing: apply overpressure at the end of available range. Don't apply the overpressure in the mid range. And this overpressure can be applied by the therapist itself or by the patient itself. So both can be done. Overpressure and the repetition both will help to gain further improvement. Mulligan technique is also about the self-treatment. A patient can get can apply these technique at home. If you taught the patient about how he or she can apply the glide, so at home he or she can apply that glide and perform that problematic activity. Or you can apply adhesive tape. With the help of the adhesive tape, the direction of glide will be maintained and the patient can perform the activity for next 24 hours. So the self-treatment is also possible with the help of the Mulligan technique, but for this, you must have to taught the patient the right direction and the right treatment plan, or you can easily apply with the help of the adhesive tapes. The next question is, if you are applying a glide and there is no improvement, patient is still having pain, so what's wrong? So, the failure of improvement in the comparable sign, mostly the therapist is applying the glide at the wrong treatment plane, or you are not at the right treatment plane and you are not checking the joint plane. So in case of the wrong treatment plane, there will be no improvement. And if the grade of mobilization glide is not appropriate, if you are applying the glide of less amplitude, or if you are applying the glide of more amplitude, so both will lead to the increase in the pain or there is no change. And in case of the spine, if you are treating a person at the wrong spinal segment, suppose a patient came to you with the lumbar pain, with the back pain, and you are treating L2, L2 and L3. You are treating the segment of L2 and L3, and you're applying the glides at the L2, but still patient said that he's having pain. It means you are at the wrong segment, so you have to go for the correct segment. Maybe the problem is of the L3, L4, or the L5. So in case of the spine, the correct selection of the correct spinal segment is very important. And the next one is the technique is not indicated. Maybe he's suffering from something else. Maybe there is acute injury, maybe some kind of the disc lanes, or maybe some kind of inflammatory disorders. So the technique is not indicated. As per Mulligan, it always improve the comparable sign. But if there is no improvement, it means you are at the wrong treatment plane, you are selecting the wrong spinal segment, or you are applying the mobilization of not appropriate grade, or the technique is not indicated at that time. So for this case, reassess the patient, again check the comparable sign, and take the history, go for the examination, and apply the different combination of the glides. So it will help to find the correct treatment plane and the correct amplitude of the glide. So Mulligan principles. After some journal principle, the two principles which were given by the Mulligan, the one is the pill response and the one is the crux. So these two are specifically for the assessment and the application of the treatment. What is pill response? So let's start with the pill response. Pill is of four things. The one is P is for the pain-free. What is meant by pain-free? The pain-free glides. This is the most crucial thing to make the glide pain-free. But yes, you have to differentiate one thing. These glides must be pain-free, but the application of glide, when you apply the glide at a point, it will lead to some kind of discomfort. So yes, you cannot eliminate the discomfort with the application of the glide, but yes, the glides must be pain-free. Whenever you apply the correct glide at the correct treatment plane, you will always get the instant results. Or if you are at the wrong treatment plane and you are not applying the correct amplitude of the glide, the patient will complain of increased pain. So the Mulligan always gives the instant result in the form of the improvement in the pain or in the form of the increase in the pain. So all Mulligan gives the instant results, and these results are long lasting. So pill response is make the glide or the make the treatment session pain free. You will always get the instant results. You don't have to wait for the 24 hours like in the Calton-1 or the Maitland. You will get the result immediately after the application of the first glide. And these improvement are the long lasting. It doesn't mean that the patient will came to you in the next day and said that there is no change. He's still having pain. Whenever you apply the correct treatment with the correct glide, those results will be long lasting. And the next one is the Crookes law. So before the application of Crookes law, the one thing which is the guide for the application of the Crookes is the pain. Pain is always the guide. If there is a pain, you are not applying the correct treatment. If there is no pain, you're going in the right direction. So pain is always the guide in the case of the Mulligan concepts. So whenever you check the pill response in the assessment, if you apply a glide and the patient said there is no pain, or he said that there is more pain, the right thing, the pain is always the guide. So with the help of the pain measurement, we will be able to go to the next step, and that is the crux. The crux is about of the six things. The one is the contraindication, R is for the repetition, O is the application of the overpressure, C is for the communication with the patient, K is the knowledge of different things, and S stands for the three different parameters. So I will tell you these parameters in detail. The one is the C. C stands for contraindication. What is meant by contraindication? Contraindication means the treatment is not applicable. So in case of the pill response, you can say that that technique and that glide is not indicated. So that technique is not applicable. Go reassess the patient and apply some other glides. So in case of pain, in case of non-production of the pill response, the treatment or direction, the treatment glide or the amplitude of the glide is not indicated. The second thing, repetition. If the patient said there is no pain with a single glide, go next, apply those glide with the repetition. Ask the patient to perform it again. So if there is no pain, perform that activity with the elimination of positional fault again and again. So repetition will improve the patient pain, will improve the range of motion, and will also improve the functional activities. Overpressure. If you want to gain more improvement, if you want to go into the next step, apply overpressure at the end of available range. The next one is the communication. The Mulligan technique is very important with respect to the patient, because in this, the one part is by the therapist and the second part is by the patient. So you have to communicate with the patient. You have to tell the patient how he or she will perform that activity, what will be the speed of that movement, what will be the range of that movement, and what will be the direction of that movement. So you have to communicate with the patient about how he or she will perform that activity. And with the performance of that activity, there must be no pain. If there is a pain, the patient must tell the therapist he or she is having pain. So the treatment from the start to the end must be pain free. But yes, there will be some kind of discomfort with the application of glide. So you have to communicate these parameters with the patient. Otherwise, you will not be able to apply a successful Mulligan approach. And the next one thing is the knowledge of anatomy of joint, knowledge of the biomechanics of the joint, knowledge of the positional faults. So with the help of these things, you will be able to apply the correct Mulligan techniques. And the last one is sustained. You therapist must have to sustain the glide throughout the range of motion. The therapist must be skilled in the application of that glide, and he must sense through what is the right treatment plane and at what treatment plane he is getting the maximum joint play. So these are the two principles which are very important for the assessment and the application of the Mulligan. The one is the pill response and the second one is the crux. If the pill response is not generated, you cannot go further. The pain is always the guide. So the best thing about the Mulligan concept is a therapist can easily decide which technique is indicated. It makes the therapist to decide the right direction, in the right glide in the right direction immediately. There is no need to wait for the next 24 hours or for the next 12 hours. So this technique is about the quickly assessment of right direction. So these are now the basic techniques which were given by the Mulligan. The one is the mobilization with the movement. Mulligan concept is also known as the mobilization with the movement. You are mobilizing passively and the patient is performing actively. So these techniques are also known as the mobilization movement. But when we study the Mulligan use MWN specifically for the extremities, for the upper extremity and the lower extremity, passive application of the mobilization along with the active mobility, active performance by the patient. And the second technique, which was purely originated by the Mulligan was the SNAGs. SNAGs stands for Sustained Natural Apophyseal Glides. The natural apophyseal glides are the part of our normal spinal movements. SNAGs are applied at the whole spine. You can apply SNAG from C1 to the end of the spine. So the snacks are for the treatment of the spinal problem. So apply the natural apophyseal glide whenever we perform the neck flexion or extension or the lumbar flexion or extension or the rotation. These rotation are these movements are the combination of the apophyseal glides, the natural glides which occur between the spinal segments. So apply those glide passively. So therapist will apply those natural glide passively, and patient will perform that activity, like the neck flexion, neck extension, lumbar flexion, or the lumbar extension. The next one is the NAG. NAG stands for the Natural Apophyseal Glide. This is different from the Mulligan concept. In this, the therapist will apply the glides, but there will be no addition of the passive active movement by the patient. Snags are of two types. The one is the nags, and the other one is the snag. Nags can be applied from C2 to C7, and reverse nags is for C7 and T1. I will tell you these techniques in detail in our next lecture. The next one, when Mulligan was working with the patient, he experienced that some patient came with the back pain, and the pain is radiating to the legs, and the patient came that he's having neck pain, but that pain is radiating in the arm. So in that cases, snags are not enough. There must be something new. So he drive the combination of two techniques and drive the one more technique, and this is the spinal mobilization with the movement. In this, the therapist applied the sustained glide as per the snag principle at the spinal segment, and the patient will perform the activity of the limb, the activity of the arm, or like the activity of the leg. So the spinal movement with the upper limb or the lower limb. So these four techniques were given by the Mulligan. MWM for the extremities, snags for the whole spine, nag for the C2 to C7, and reverse nag for the C7 and T1, and the spinal mobilization with the upper limb and the lower limb movements. So these were the basic techniques, and we will study these techniques in detail in our next lectures. Mulligan also gave some basic principles which were related with the classification of the joint. He divided the joint into two categories. In the extremity, there are two types of joint. The one is the hinge, and the second one is the adjacent joint. Hinge joint are those in which there is the end-to-end articulation between the joint surfaces, like the fingers. You can see that in the fingers or the metacarpal phalangeals. These are the metacarpals, and these are the phalanges. So these joints are the hinge joints. And there are some joints, they also are the adjacent joint, like in case of the joints between these metacarpals, when the bones are attached in this direction. So when the bones are in this direction, these are the hinge joints, and when the bones are attached side to side, these are the adjacent joints. So, or the parallel joint. So in case of the hinge joint, apply the mobilization glide at the right angle to the movement. So the direction of these glide will be the medial or the lateral. You can get example is of the knee joint. Knee joint is the end-to-end articulation of the lower end of the femur and the upper end of the tibia. So the femur and the tibia both act as a hinge joints, and for the correction of the positional fault, you can apply the glide either in the medial direction or in the lateral direction. This is the diagram of the knee joint. You can see that the flexion extension treatment plane, and the therapist in the other diagram, the therapist is applying the lateral glide with the help of the bell, and the patient will squat when therapist will apply the glide, and the patient will go into the squatting position. So this squatting position is actually the active movement, which is also adding the resistance, and it leads to the correction of the positional fault. The parallel joints or the adjacent joint. In these, as I told you earlier, in this, the joints will, the bones will be attached from side to side. So you can give the example of the superior radioulnar joint and the inferior radioulnar joint. These joints are formed by the side to side articulation of the radius and the ulna. These joints are also present between the metacarpals of the hand or the metatarsal of the foot in case of the tibia and fibula. In, in the treatment of these joints, the direction of glide will be in the upward or the downward direction. So you can correct the positional fault in the upward or the downward direction. This is the diagram of the radio-ulnar joint. The radius and ulna articulate at the 2 point at the superior. There is the head of the radius which articulate with the ulna. At the lower end, there is also articulation of the radius and the ulna. At this point, you can see at this point, both are articulating. This is the inferior radioulnar joint and this is the superior radioulnar joint. So the next thing is the spine. What is the treatment plane of the spine? In the spine, there is the change of treatment plane at each level. The spinal segments are not stationary, they are not of the same shape. The C1 is different, the C2 is different, and even L4, L5 are different. The spinal segments are kept on changing from C1 to the L5 and S1. So there is no one specific treatment plane in case of the spine, but always remember one thing. Whenever you apply a glide, the direction of glide must be towards the eyeball. This is the main principle. You can see in this diagram, the spine is kept on changing. The spinal segments are totally changing, and at each level, there is a change in the treatment plane. At the upper cervical, if we talk about the C0, C1, and C2, the direction of glide is horizontal towards the eyeball. But when you go to the down to the spine, the direction of glide is in the 45-degree. But when we go at the lumbar region, the treatment plane is like this. So apply the direction in the at the 90-degree of angle. So the direction of glide will always change in spine, but all you always have to keep that the direction of glide towards the eyeball. In the other diagram, you can see that the Mulligan itself is applying the glide at the lumbar region. He's using the traction belt for the application of traction belt, and he's applying the glide with the help of the hand. And the patient is going into the flexion, lumbar flexion. So it's a combination of therapist applied passive mobilization with the active performance of movement by the patient itself. Now, glide mobilization is always only successful only in one direction. So you cannot say that on the first day you were applying the glide in the medial direction, that was successful, but next day you applied the glide in the lateral direction, that was successful. No. In case of the correction of the positional fault, the glide direction is always successful only in one direction. You cannot say that you can apply the both glide for the correction of a positional fault. These are some key points, so you can see that these are some points which were claimed by the Mulligan, which according to Mulligan, these points make this school of thought unique as compared to the Carlton Moore and the Maitland. The one is the weight-bearing position of the joint. All the techniques of the Mulligans are in the weight-bearing position. In the previous diagram, the patient was in the standing position. The standing is the weight-bearing position. The secondly, the sustained and range pain-free glides. The Mulligan uses the pain-free approach, and it gives the immediate and sustained improvement. The third and the last one is the passive mobilization with the addition of active range of motion. But there are few techniques in which when patient is not able to perform or when a movement is difficult, the therapist will perform that movement. So with the addition of the active movement or the passive movement, and the last one is the resistance application. There are some techniques in the patient is going or performing resisted exercise, as in the squatting, the body weight is act as a resistance, or in case of the tennis elbow, you can use a dumbbell as a resistance. So it is not about just the active range of motion, it is also about the passive range of motion and the resistance application. So it was all about the Mulligan school of thought. So I will revise some key points of the lecture. Some positional faults which were given by the Mulligan. The Mulligan approach is about the correction of the tracking problem of the joint. With the application of the right direction glide, you can correct the positional fold, and patient will be able to perform that activity without the pain. The second one is the treatment principle. The two main things which were given by the Mulligan. One is the pill response. Pill is the pain-free, long-lasting, instant results. If there is no pill response, you have to go for the crux. The crux is if no pill response is generated, the technique is not indicated. Apply repetitions. Give overpressure at the end of available range. The therapist must be familiar with the knowledge of the treatment, of the joint anatomy, and the correct treatment plan. Always communicate with the patient about the technique and to make the treatment pain free. And the last one is the glide direction of the glide must be sustained, and the patient and the therapist must be skilled enough to apply those techniques. So the next one, we go through the techniques, the four techniques which were given by the Mulligan. The one is the MWN, mobilization with the movement for the extremities, and the second one is snacks. Are the sustained natural epiphyseal glide, which can be applied at the whole spine. And the third one, which was given by the Mulligan, nags. Are the natural epiphyseal glide. You can apply nags at C2 to C7 and the reverse snag at C7 and the T1. And the next technique which were given by the Mulligan was the spinal mobilization with the limb movement. This was in case of the radiating pains or in case of neurological issues. So this was all about the Mulligan school of thought and the Mulligan concept. The homegoing lesson is learn something new every day. As today we studied a new concept of the manual therapy. So in daily lives, you don't stay lazy. Don't be lazy. Learn something new. It will add something new in your bag. Add some new skill daily. So in this way, you can improve yourself. You are the competitor of yourself. You don't need to compete with any other person. You have to improve yourself from day one to the day two. This is the main thing. So in how you can do this, you can improve yourself by learning new things day by day. Thank you for listening. You can ask any question in the comment box, or you can communicate with me in the live interactive session of the meet. Till then, take care. Allah Hafiz.